General Secretary, Madam President and colleagues. My name is Carmel. I'm a CNS and tissue viability in the community in Kildare and West Wicklow. When Phil asked me to do this presentation, I didn't realise the calibre that I'd have to follow after the other speakers. So you'll be delighted to know my presentation is very short and sweet and to the point. I'm just going to go through my background and how I became a CNS in the community. I commenced as a community RGN in 1994. I initially worked in Rathfarnham in Dublin. I transferred down to Kildare in 1996, and I was a community RGN until 2002. And I suppose I got increasingly frustrated in the community in the sense that we could be waiting 6 months for a vascular consult for a patient when we knew in our hearts and soul this was a genuine venous ulcer, but we weren't performing Dopplers in the community. So we were waiting long times basically for people to be seen in the vascular departments, and I got so frustrated I decided I would go off and do my HDIP in wound management. So I did that in the Royal College from 2002 to 2004. I started acting as a tissue viability nurse in the community from 2008 to 2013, and luckily Haddington Road came along and I got my CNS post because I had been acting in that post for over 5 years. I was initially in Newbridge Health Centre, and then I set up a wound clinic in Vista Primary Care in Naas in 2011. So I converted to the CNS post in October 2013. And my role is to manage the wound clinic, and I also do home visits when necessary. These would be for patients who are either housebound or have no transport or are terminally ill or bedbound. I established rapid access to the vascular services in Tallaght Hospital in conjunction with Professor Sean Tierney, which is an absolute fantastic access to have. We did have an outreach clinic in the Vista Clinic until mid-2015 in conjunction with Martin Feely, who would be one of the vascular consultants in Tallaght Hospital. But unfortunately, when he left his post in Tallaght, that was the end of our clinic. But since then, at least I have established that quick access, so I can refer anybody that I'm worried about up to Tallaght by email, and the Professor Sean Tierney will see these referrals and he decides, how urgent they need to be seen, which is a fantastic resource to have. I also have access with the multidisciplinary diabetic foot team in Tallaght, which is fantastic. And for anybody who works in the community who knows the problem that we have with diabetic foot ulcers, this service is fabulous. They can be seen within a day if they're referred up to the chiropody department in Tallaght, and they are screened and they are seen in the multidisciplinary foot clinic, and treatment is initiated and continued in the community. I link in with Gillian O'Brien, who's the AMP in Naas General Hospital, and I would attend their wound tissue viability meetings. So I have that great link with Gillian. I provide education to the community nursing staff. I sound like a great person. Stats to date, I suppose until 2011 when I was acting in the post, I didn't really keep stats because I was a community RGN, so I was trying to do 2 jobs in one. But I suppose since 2011 I'm probably better. I have established a database, so I've seen over 5,000 patients between the wound clinic and home visits. The number referred to vascular, it sounds like a lot in the 570, but that would be including the number of patients who would have attended the outreach clinic. That was run just once a month for a morning session only, and we'd have 14 to 16 patients attending that. So it sounds like a lot of numbers, but it's including those. I've performed 1,386 Doppler assessments. There are plans to employ a podiatrist for the diabetic foot ulcer care in Kildare and West Wicklow. We had thought we had a podiatrist, but she finished before she started and it didn't come off. So we're actually waiting for that, which would be fantastic. We could actually set up a routine foot screening clinic, which I'd really love to do because diabetic foot disease is rampant out there. And if we could prevent one amputation, I really feel we would have achieved something. The plan would be to hopefully develop further leg ulcer clinics, because I'm the only one in the county with the leg ulcer clinic. Now, luckily enough, 2 other RGNs have gone and done their HDIP in tissue viability, which will be a great resource, and one of them, I'm hoping, will be able to set up a leg ulcer clinic north of the county of Kildare, which would save all of those patients coming to see me. And also she at the moment is doing Doppler assessments for patients who require compression hosiery, and she will see some wounds as well, which is great, and the other nurse hopefully will develop a role for her. So the benefits of the tissue viability service in Kildare and West Wicklow, it's a valuable resource, I hope, for community nursing and GP practices. The vast majority of my referrals come from the community nursing teams. GPs will refer from time to time, but it's basically the community nursing teams. I'll take self-referrals, providing that the patients just get a cover letter from their doctor, so I know their medical history, I know what medication they're on. And I have regular ones that as soon as they're healed, and if they have a leg ulcer and they're healed and it breaks down again, they generally will just ring me and I will see them as soon as I can. I manage appropriate referrals for the vascular consults and diabetic foot clinics, ensuring rapid access. So this is a valuable resource. So basically, when I do my assessment and perform the Doppler assessment, depending on the results of the ankle brachial pressure indices, I will refer those to TALA if they are below the guidelines for compression therapy. The vast majority of my patients, I have to say, are leg ulcers, and I love them. There's obviously something wrong with me, but I do love them. I just love the challenge, and I love to get them into the proper treatment and get them healed. And then for the ones who are not suitable for compression, they will be referred to vascular. They'll have whatever investigations they need done in TALA and the appropriate treatment initiated. The amount of people that I have seen will reduce the already overcrowded OPDs. The vast majority of these patients are elderly people who basically may have to go to an outpatient department and spend a whole morning at that outpatient department or go in the afternoon. Their families have to take a half day off work or a day off work. So it's fantastic for those people. It's also reducing the burden on the OPDs. It enables patients to be treated locally, and I will do the home visits wherever necessary.